So good morning, everyone. Welcome to the doctoral capstone presentation for our doctoral candidate, Amanda Lange. I just want to give a few updates first. This is always a wonderful day of celebrations, but I also, it's been a very tough few months for the entire world. So I just wanted to give a shout out as well to many of our doctoral students as well who are doing great work, productive work wherever they are in the world. Some of them have been very busy and productive during the doctoral program, and after the doctoral program, we have some updates that I just wanted to quickly summarize. I'm going to ask everyone actually to please put their audios on mute so we minimize any extraneous noise. You can keep your videos on if you want. But is Dr. Simon here right now? She's going to join us. Dr. Simon just got promoted to assistant professor at Columbia. Dr. Josh Kotler, who finished his capstone last summer, is now clinical assistant professor at USC. Michaela Fraser, who's right here with us, is now assistant professor at LIU. Scott Rashanan and I just finished a book chapter that's now in press. Several of our OTD students and graduates also just got papers accepted. Dr. Daniel Alonzi Gold is here, who had a paper accepted in OJOT, the Open Journal of OT. Christina Dumas had a paper also accepted in OJOT. Amanda just got her paper accepted in OJOT this Monday. Dr. Stephanie Hoy is here, and with one of our other students, Tiffany Shah, just published an interactive children's book now available on Amazon. Congratulations. Mary Arnaud, Scott Rashanan, and Dr. Danielle Mahoney just presented recently at the JFK, the Dr. Janet Focaster Distinguished Lectureship. One of our new OTD students, St. Clair Andrade, recently presented at the New York State OT Association Conference. And Mari Arnaud recently guest lectured on literacy invited by Methodist University. So really a lot of great work from our OTD students, great productivity recently. And like I said, today is really a celebration and a culmination of a lot of work from the past 2 years. But before I turn it over and introduce formally our doctoral candidate, I'm going to ask Dr. Glenn Gillen for some short words of welcome.
Good morning, everybody. This is an exciting day. I feel not special because I'm only in Long Island. I'm not in Singapore. I'm not in Japan. Amanda, I feel like I've known you for years now, and it's so proud to see you come this far. Everyone who's in this program, congratulations. You see that the product that we graduate is outstanding. For those of you who have been working the front lines, thank you on behalf of all of us. And please stay safe, yourself and your families. And whatever holiday you celebrate, happy holidays to you. And Amanda, I can't wait to hear you today.
Thank you.
Thank you, Dr. Gillen. So we're going to get started. This will be our format. Our doctoral candidate will be presenting for the first 30 minutes, followed by about 20 to 30 minutes of open scholarly discussion. The first 10 to 15 minutes will be devoted to the doctoral candidate's capstone committee and reader, and then we will open a moderated question and answer in the next 10 or 15 minutes. What we mean by a moderated question and answer is that at any time during the presentation or during the discussion, if you have any questions, feel free to use the chat function on Zoom to type in your questions. And then I will be moderating, either thematizing or choosing particular questions to address to our doctoral candidate. I'm going to now introduce our doctoral candidate, Amanda Lange. Amanda Lange has a background in early childhood development and received her Bachelor of Arts in Early Childhood Education from Florida Gulf Coast University in 2013. She received her Master of Science in Occupational Therapy from Columbia University in 2016 and has worked at Nationwide Children's Hospital in Columbus, Ohio since 2017 as a pediatric occupational therapist. There she works in the inpatient acute care, outpatient, and burn clinic practice settings with a variety of ages from birth to adulthood. Children on her caseload led her to identify the gap in occupational therapy research related to adolescents with burn injury and social participation. This gap has led her to develop the Social Participation Index for adolescents with burn injury. Her capstone has focused on the development of this screening tool and the establishment of its preliminary validity. On a personal note, over the past 2.5 years, it has been my absolute pleasure working with Amanda. Her dedication and passion for this work, not to mention the intensity by which she does it, has been truly remarkable. And I'm grateful for the opportunity to have worked with her on this. I co-authored with her such a detailed practice guideline informed by the work that she has done in the program and started in the OT theory class that she took, which we submitted, which she submitted to the Open Journal of Occupational Therapy. As I've mentioned earlier, that manuscript was accepted for publication this Monday. So it is my pleasure to present to you, to present her capstone work, doctoral candidate Amanda Lange. And again, I'm going to ask everyone to go on mute, please, throughout the duration of the presentation. Once again, our doctoral candidate, Amanda Lange. Amanda, take it away.
All right, I'm going to share my screen here with everybody. All right, thank you everybody for coming this morning, and thank you Dr. Rajo for the introduction. I have been a pediatric occupational therapist at Nationwide Children's Hospital for 4 years, where my work on the inpatient, outpatient, and burn clinic settings have led me to pursue this doctoral work related to improving assessment and intervention of psychosocial aspects of adolescents with burn injury. Psychosocial is defined as the interrelation of social factors and individual thought and behavior. Often in our burn clinic, I would very briefly ask how things were going outside of the healing process, like in outside activities or at home or while at school. And I was often met with the adolescent, fine, good, yup, kind of one-word responses. It was only after accidentally overhearing some remarks or side conversations between these adolescents and parents while going in and out of the rooms where I realized that the self-perception of these scars, regardless on how severe or how visible, were dictating some of the decisions related to social participation that these adolescents were making. As occupational therapists, not only do we have strong roots in mental health, but we also bring a unique lens of mental health practice that focuses on function and participation. So when I realized that this is an area that was potentially being overlooked in the burn clinic settings, I felt compelled to explore what role occupational therapists can serve in the psychosocial aspects of burn injury in order to support best practice and strengthen interdisciplinary collaboration on our burn teams. So I'm going to start by discussing the background of my capstone project, which is titled The Development of an Assessment Tool called the Social Participation Index for Adolescents with Burn Injury, or the Spi Burn, which is how I will refer to it for the rest of this presentation. So adolescents with burn injury are vulnerable to psychosocial dysfunction due to the complex nature of their neurobiological, cognitive, and interpersonal changes that occur during this developmental stage. Physical differences in appearance also make these adolescents prone to peer bullying and at further risk for social functioning challenges. This may involve underlying difficulties with cognitive functions needed to support adaptive social functioning, and it can present as social isolation, inappropriate social behaviors, or social anxiety. Social participation is a recognized intervention to promote positive mental health, and it's necessary for identity formation during an adolescent's transition into adulthood. However, there's a current lack of available assessment tools for evaluating social participation difficulties for adolescents with burn injury. And furthermore, there's a lack of literature supporting the role of occupational therapists in psychosocial domains for pediatric burn injury, despite a clear alignment within our scope of practice. So as mentioned, occupational therapists have a scope of practice with the unique skill sets to address psychosocial difficulties with a focus on function and participation. By developing a screening tool from the lens of occupational therapists, this may assist in bridging the gap between available tools used for psychosocial assessment, promote interdisciplinary collaboration, and provide more comprehensive patient care for this population. So my capstone project and the process really focused on 3 elements. The first was conducting a scoping review to find gaps in the literature regarding assessment tools that address psychosocial domains for pediatric burn injury. The second was developing the Social Participation Index for adolescents with burn injury to screen for psychosocial dysfunction for this population. And the third was conducting a research study to establish preliminary content validity and clinical utility in order to assess the initial psychometric properties of the SPI burn. The goal of the Columbia OTD program is to create clinicians that are agents of change and still embodying my inner New Yorker. I like to think of my pathway through this doctoral journey like a New York City subway line. So in true Columbia University Medical Center fashion, starting up at the 1 train is where my program artifact development began, and the related coursework that guided these developments correspond over on the A and C line. My program artifact development began with creating a theory-guided practice model, as well as a neuroscience-focused case study, served to guide and shape the cognitive components of my capstone project. The theory-guided practice model melded a variety of occupational, neurological, and developmental theories to assessing social, behavioral, and cognitive dysfunction and how to respectively approach intervention for adaptive social functioning. Together, these theories explain why adolescents with burn injury are 1, in a sensitive time period where social participation is critical for promoting mental health and well-being, 2, at risk for executive functioning difficulties related to social participation, and 3, in need of cognitive-based intervention strategies to prevent lifelong detrimental effects. The overall goal is to improve the adaptive capacities of adolescents with burn injury to promote social participation using a cognitive approach to intervention. Adaptive capacity is defined as the tools, strategies, and mechanisms that are planned, generated, and evaluated in order to overcome challenges encountered in familiar and unfamiliar occupational environments. For adolescents with burn injury, adaptive capacity therefore describes forming a set of cognitive tools in order to navigate one's own behavioral, cognitive, or emotional responses during social activities or contexts, and act or respond in a way that supports participation. When I first drafted this practice model, it was straightforward with more occupational and developmental theories. But throughout progression of program coursework, I continue to fortify it with the neuroscience and cognition pieces, which I really believe encapsulates a more holistic picture for assessment and intervention. According to the practice model, to optimize one's adaptive capacity for social participation, one must maximize indicators across 3 domains, which you can see here. The behavioral domain includes behavioral actions of adolescents that support social participation in desired occupational contexts or environments, irrespective of their burn injury. So contrary to behaviors such as avoidance, withdrawal, fear, anxiety, before or during or in anticipation of social activities, these behavioral indicators of this domain include accepting invitations to social activities, building supportive relationships with peers, initiating social interactions, willingly going out in public or to new social settings, and welcoming or embracing opportunities with peers, families, or others that they would otherwise be inclined to do so regardless of their burn injury. Social cognition is the next domain, which you can see in yellow. Social cognitive skills are one's executive functions and self-perceptions that promote social participation. These executive functions include one's decision-making, inhibition and judgment, emotional regulation, and self-efficacy. And they are exemplified here in this chart. So decision-making is important because one's perceptions and feelings about their scars influence the decisions that they make, such as their clothing choices, grooming and cosmetic routines, who they socialize and interact with, or how they socialize or pursue others of romantic interest. Inhibition involves one's behavioral impulses. For instance, if they automatically tend to reject social invitations or impulsively avoid opportunities to go new places or interact with new people. So here, one is able to recognize these behavioral impulses, and they're able to control or modify their behavioral reactions or responses to promote participation in activities. As literature supports links between our emotions and behavioral responses, emotional regulation skills are critical for supporting social participation. Emotional regulation is one's ability to recognize their own emotional state and adjust, modify, or regulate these emotions so that they're open to more social opportunities, adaptable during social interactions, and can develop skills that foster friendships. Self-efficacy is one's own belief in their capabilities to be successful during social participation. One believes that they are capable in participating, managing, or navigating desired or unanticipated social contexts, such that they're continued to be motivated to pursue social opportunities. So lastly, in the blue circle is the resilience domain. Resilience theory focuses on improving one's internal and external promotive factors. Internal promotive factors, known as assets, are one's intrinsic factors that support adaptation to adversity, such as self-efficacy, sense of identity, and stress management. External promotive factors, known as resources, are exterior supports to adaptation, such as adult mentors, support groups, and youth programs. By maximizing promotive factors, one can achieve optimal resilience and foster adaptive behavioral patterns. This way, adolescents can respond to stress, recover from adversity, and navigate challenging social situations so that they're continued to pursue social opportunities ongoing and in the future. So I created the Participate framework to guide intervention from these theories using a cognitive approach, which you can see here has 8 essential elements. These are metacognitive strategy training, emotional regulation, social occupations for identity formation, self-efficacy, access to social supports, mentorship, interdisciplinary practice, and ongoing self-assessment. In harmony with OT practice, this framework takes a strengths-based approach to promote enhancement of the behavioral, social cognitive, and resilience indicators to support optimizing one's adaptive capacity for social participation. So in addition to this practice model, I also completed a case study on an adolescent with burn injury, looking at the neuroscience that may underlie and explain his behavioral presentations in social context, and theory to speculate on the relationship between the cognitive functions, presenting behaviors, and participation in daily activities. I reviewed the impact of the development of the prefrontal cortex and limbic systems during adolescence and the relationship of these systems on functional performance and behavior patterns. I also juxtaposed the potential influence of these cognitive systems on emotions and decision-making patterns and the relationship between presenting dysfunctional behaviors in homeschool and community settings. This all helped contribute to my practice model and assessment tool development. So moving on with my educational and continuing education artifacts, which are represented up closer here. So I presented aspects of my practice model at the first annual Dr. Janet Fall Kessler JFK Distinguished Lectureship and Day of Scholarship in May 2019. It was titled A Cognitive Approach to Improving Adaptability of Adolescents with Burn Injury to Facilitate Social Participation and Decrease Mental Health Risks. I was also accepted to present 2 posters related to the development of the SPI burn and this practice model at the American Occupational Therapy Association National Conference. To promote preliminary transfer of this work into a clinical setting, I also provided an interdisciplinary in-service on the development and use of the SPI burn tool. So scrolling down and moving on to the evidence-based practice artifacts. Through my coursework further in the program, I developed a mini critically appraised topic paper, developed the SPI burn assessment tool, and a grant proposal to support psychometric property testing, which I will discuss further here. I conducted a scoping review to identify the assessment tools used by interdisciplinary burn team professionals for pediatric burn injuries in the post-acute stages across various settings. The aim was to identify the assessment tools relevant to psychological and psychosocial domains of pediatric burn injury currently used by interdisciplinary team members. The second goal was to reflect on the individual and interdisciplinary roles that occupational therapists can fulfill in post-acute care for children with burn injury. From the scoping review, I was able to establish that there is a clear need for more burn-specific outcome measurements for pediatric populations with burn injury, and that occupational therapy was a highly underrepresented discipline in the literature for both the involvement within research studies and for using assessment tools with this population. Furthermore, it was found that less than 1/3 of the 156 identified assessment tools were actually burn specific, meaning they were designed for specific use with burn injury. So I'm going to spend the rest of my remaining time discussing the development of the SPI burn and my research findings. The purpose of the SPI burn is to screen for cognitive, environmental, and behavioral functions supporting adaptive social participation. It is designed as a screening tool to match the brisk pace that is often found in outpatient follow-up settings. It is a self-report focused on how an adolescent perceives their own social supports, their own decisions, and their own experiences related to their burn injury and social participation. And it uses a 5-point rating scale of agreement. It's targeted for adolescents ages 12 to 17 years old who have experienced a burn injury of any size, severity, or location. And it is divided into 4 domains. The access to social supports domain is intended to depict the adolescent's current social supports in place and desire for additional resources or supports. The social experience domain is intended to assess the actual experiences that the adolescent has undergone during current social participation experiences related to their burn injury. This includes experiences with bullying, loss of friendships, missing out on social events, or inability to participate in social activities due to their injury. The social cognition domain is intended to depict crucial cognitive functions, such as decision-making, emotions, and self-perceptions related to an adolescent's altered appearance that may interplay to influence adaptive social participation. And the resilience domain intends to capture the adolescent's ability to overcome social adversity or setbacks, such that the adolescent is not further discouraged from pursuing social opportunities and does not harbor negative emotions related to poor self-efficacy or self-esteem as a result. So these are example questions and example formatting from the SPI burn tool. The categories are divided by color, and the graphics are to support responses on the scale. So here is an example of one of the domains, access to social supports. So if we look at question 1, the adolescent would read the question, I feel like I have friends and or family who accept me for who I am and how I look. And they would answer if they strongly agree, feel neutral, disagree, or strongly disagree with the statement. Since it is a self-questionnaire, questions were designed using the Flesch-Kincaid reading level formula, in which the grammatical and lexical complexity was rated a 7.3, indicating an average reading level for about 12 to 13-year-olds, which is on the low range for the age group that this tool is designed for. Administration should also only take about 5 to 6 minutes to complete, and it should take only about 1 to 2 minutes to score, scale, and determine clinical implications. So after it is completed, you use the scoring sheet to give each answer a numerical value. You then take the sum of each category and place it on the rating scale, which is seen to the left. Ratings that indicate high support for social participation in a domain do not warrant further assessment or intervention. Ratings that indicate moderate support warrant further questioning in those subdomains and advisory to relevant disciplines. Ratings that indicate low support for social participation will indicate referrals to interdisciplinary team members. Therapists are encouraged to collaborate with team members to add feasible implications to the chart, specific to their own team and local resources. The goal of the index is to guide clinicians to connect clients to resources, provide further assessment, provide intervention, and triage referrals to interdisciplinary team members. So this is an example of a clinical implications chart. If you rate low for access to social supports, potential steps you could take are providing with community activity resources, connecting with the social worker or a case manager if that's what your site uses, linking with burn-specific support groups, and recommending burn camps. So after creating the tool, I conducted a research study to establish preliminary psychometric properties of the SPI burn. IRB approval was obtained, and for the content validity study, 8 clinicians from different disciplines, including occupational therapist, physical therapist, and psychologist, representative of interdisciplinary burn teams, were recruited to serve as content experts for determining the validity of the question content for this population. Content validity ratio, known as CVR, as well as probability of chance agreement, were calculated to determine essential items on the scale in order to condense the tool and strengthen the relevant content. Participants of the expert panel each received a copy of the assessment tool and a questionnaire with a 3-point ordinal data scale to evaluate if items are critical for measuring the construct of adolescent social participation. This included ratings of not necessary, useful but not essential, or essential. So this is a graphic depicting the results. The content experts agreed that 18 out of the 30 items on the SPI burn are essential items. 7 items, shown in the darker green, rated a high CVR of 0.75, which is deemed a critical value for a panel of 8 experts. And 11 items, which are shown in the lighter green, were rated a CVR of 0.5 or higher. Although this is not the critical cutoff value, it indicates that more than half of the reviewers deemed these items as essential, and therefore they went under further review and revision before determining their remainder or removal from the tool. 12 items were deemed non-essential, 1 from social supports, 1 from social experience, 3 from body image, and 7 from coping skills. 2 items, seen over in yellow, were rated low CVR scores, but were kept as more than half the reviewers rated these items as essential, and literature also supports that these 2 items are important items for body image and coping skills. Therefore, a total of 10 of the original 30 questions were removed from the questionnaire, while the phrasing and language of 13 items were also revised to be more developmentally appropriate. 4 of the items were condensed into 2 items to be more concise based on the qualitative feedback. The body image domain was renamed to social cognition, and the coping skills domain was renamed resilience, corresponding with question revisions and more appropriately reflecting the literature. To establish clinical utility and validity of the SPI burn, 21 occupational therapists across 9 different states and 2 countries who have worked with pediatric burn injury were recruited using convenient sampling within known hospital networks and online community occupational therapy forums. In addition to spanning a large geographical area, participants also had a wide variety of experience in clinical settings, including inpatient, outpatient, early intervention, mental health, schools, and community practice settings. Participants also had a wide range in their years of experience, as 33% of participants had greater than 15 years of experience, while 23.8% of participants had 8 to 10 years of experience. 28.5% had 4 to 7 years of experience, and the rest had less than 4 years of experience. Participants reviewed the SPI burn and provided qualitative feedback to 6 questions regarding the usefulness in clinical practice, ease of administration, implications for interdisciplinary practice, and projected opportunities and challenges. Clinical reviewers found that the SPI burn is an applicable and potentially useful screening tool in outpatient practice settings for adolescents with burn injury. 4 themes emerged from analysis of the clinical utility responses. the SPI Burn is one, a potentially helpful tool that may expand the role of occupational therapists for this population. Two, a relatively easy tool to use that is feasible to administer. Three, practical for early identification of coping and supports. And four, useful for making referrals to other disciplines and promoting interdisciplinary collaboration. So here are some examples of feedback supporting the development of these themes. In the first theme, that the SPI Burn could potentially expand the role of occupational therapists, one participant quoted, "I feel it would be very helpful. As an OT with burn patients, you see them sometimes daily and develop close bonds. As OTs, we are in a unique position to make referrals to other services." In the second theme, easy to use and administer, one participant quoted, "I feel this would be an easy tool to administer to our adolescent population. We could use this in the wound clinic when they wait in the waiting room and can review as needed during their appointment." In the third theme, that the SPI Burn could support early identification of coping and supports, one participant quoted, "I think it could help to identify issues early before they progress into teens or adolescents, such as depression, anxiety, or nightmares before they worsen." And in the fourth theme, promoting interdisciplinary collaboration and referrals, one participant quoted, "If a pattern is noticed in their answers that they are avoiding certain activities, this could be used to further discuss counseling, therapy, or other needs that they feel may ease these concerns and lead to bridging this gap." The revised SPI Burn tool now has 18 items, 4 in the social supports domain, 4 in the social experiences domain, 6 in the social cognition domain, and 4 in the resilience domain. For our conclusions, the SPI Burn shows initial content validity and potential usefulness in clinical practice in outpatient settings. Future research directions include the need to establish construct validity of the tool to ensure that it follows measuring the one latent variable, social participation. Okay, and so moving down. Lastly, I have transformed my practice model into a guidelines for practice manuscript. It was submitted to the Open Journal of Occupational Therapy, also called OJOT, which has since been accepted for publication as of this Monday. I also have a second manuscript being developed and written for the psychometric property testing of the SPI Burn. While completing the doctoral program, I worked full-time at Nationwide Children's Hospital in Columbus, Ohio, which served as my clinical residency. Nationwide Children's Hospital is one of the country's largest not-for-profit freestanding pediatric healthcare networks. I was afforded the opportunity to work with a variety of individuals with burn injury of different ages. I was able to gain valuable hands-on experience with my target population to guide my scoping review, inspire development of my assessment tool, and promote development of my practice guidelines. So scrolling through this process, I would like to end here with my representation that my journey on the 1NA train has brought me to 59th Street, Columbus Circle, where I correspondingly reside here in Columbus, Ohio, that is. But it is also significant to me as it is the entrance to Central Park. And to me, that symbolizes the ongoing growth that I will continue to carry throughout completion of this program. This program has shaped me to be a leader in the field, both interpersonally and in my workplace, improve my own mentorship abilities that I can provide for students, and ignited the enthusiasm for continued research and evidence-based practice contributions to the field. Looking forward, I plan to continue this research by piloting an intervention study using this tool to support evidence of the practice model after the construct validity is determined. Methods to translate the SPI Burn into HIPAA-approved electronic format is also being explored, as literature supports that tablets-based formats, children are more inclined to answer more truthfully and demonstrate increased spontaneous self-disclosure. I am incredibly thankful for feeling as though I have the tools to pursue not only future research topics in this specific area of practice, but also future evidence-based practice topics in general in occupational therapy practice as well. I would like to take a moment to acknowledge and thank all of the Columbia faculty who helped challenge, inspire, and transform me into an agent of change within my profession, and feel this humble competence to embark on new research paths and continue to contribute to the evidence-based practice in occupational therapy. A special thanks to my doctoral mentor, Dr. Lange, who helped me take my once very large ideas and slice my pie smaller, as we like to say, to have a more clearly targeted and focused research path. My capstone reader, Dr. Janet Fall-Kessler, for careful review of my doctoral work artifacts. My coworkers at Nationwide Children's Hospital, my Columbia alumni OTD colleagues who served as inspiration and support, my boyfriend Mike, who put up with my not so typical sleeping habits and schedule, my parents, Doug and Lisa, for always being so incredibly supportive of my goals and aspirations, and all of my friends and families who have supported me unconditionally throughout this process. I thank you all so much for being here today. I look forward to the future research on this topic, as well as occupational therapists expanding in this practice area. Thank you.
Let's give a quick reaction icon for Amanda. Congratulations. Thank you. And Amanda, you can stop your screen share now. We're going to open it up now for discussion, scholarly discussion by Amanda's capstone committee that will be led by me as Amanda's mentor, and Dr. Janet Fall-Kessler, who is our capstone reader. Dr. Fall-Kessler, do you want to get started? Unmute, please.
Sorry about that. First thing I wanted to say is I absolutely love your project. I really do. I learned an incredible amount from it. You know, I reviewed everything quite a number of times, more for me to really gain the knowledge that you put out there. Working with people with burns has never been my area. Mental health is. So I really loved, you know, what you did. The other thing I wanted to start off by saying is that, you know, I think every occupational therapist really has an obligation to think like an OT always, and not get sucked into these other medical models and almost, you know, appear like other professions, but also to get other people to really understand that what we do and how we think doesn't fit into a box, is not linear, and changes lives in very meaningful ways, and you have done that. And so I do want to congratulate you on that. So there are a lot of things. I mean, if we had a day, you know, to talk about stuff, there are a lot of things that are in my head, but I really will narrow it to just a couple of things that, you know, that I think it helps to put your project, helps to operationalize it, you know, really get it out there so that people can get involved. One of the things that came to mind in general, you know, when you were talking of and incorporating the whole notion of resilience, which is critical. And I don't think OTs do enough of that, but understanding resilience is so critical to well-being and participation, as you know, and you've noticed its importance. But what I'd like to suggest is that, and there is evidence for this, and that is that occupational therapy, in fact, facilitates resilience. It doesn't just address it or, you know, think about it, oh, good, let's make them, you know, they're now showing and or being more resilient, but we can do very specific things to make sure that different resilient factors come into play. This is one of the things that I think is really important. And I just wondered, you know, in addition to the fact that you've included resilience in this, is whether or not you can comment a little bit more on how you came to look at resilience and how OTs can really make that part of their, you know, how they can really use OT to facilitate it.
Sure. Great comments. I appreciate how thorough you reviewed all of the artifacts. And for me, when I started thinking about resilience, I felt like it was really the missing piece that would decide transfer and generalization of actual change. We can't predict the amount of the amount of social context situations that an adolescent will encounter in their life. So if we are not able to foster and facilitate, as you said, resilience within these adolescents, then our intervention is only going to do as good as it is for the things we practice for in sessions, which would be impossible to sustain because we just don't know what they will encounter, who they will encounter, and what situations they will face in life. And so for me, resilience was really the piece that made, and fostering resilience is the piece that makes this intervention sustainable and true change. And so that's the piece that for the practice model with the intervention, really the intervention is looking at building those internal promotive factors, the things inside of you, like your emotional regulation skills, like your feeling of self-efficacy, as well as the things outside of you, those external promotive factors, like your social supports, your family or friend supports, your sense of occupational success. So supports and other things like I'm good at doing this. This is my team. I'm part of this team. I'm part of this group. In order to help facilitate that resilience. And that really comes into play in the practice model.
Yeah, one of the things that I also, that certainly taps on everything you've just said, is your framework is such a systems perspective. The loop that you created. There actually, there's a professor from MIT, Peter Senji, who has designed all kinds of feedback loops that really helps force people to think in terms of systems. And I think what your project certainly is showing, that you are thinking systems. Resilience is part of that because coping fosters resilience, resilience fosters coping, that fosters social participation, and so on and so forth. So it's this constant loop, which is really, really important. The other thing that I was really, looking at, and I know nothing about instrument development, in terms of, what you designed, I thought it was wonderful. I love the questions. I love the fact that it's quick to fill out. I was stuck a little bit with the category of moderate, because from a subjective perspective, to me, moderate is, oh, that's okay. But clearly a score of 11 is not, and that's a moderate score. The fact that it requires people to look into that section. If anybody has a moderate, you don't get a pass. It's not neutral. I really like that. And what I kept thinking about, and I'm wondering if you could also comment on this, is that I started thinking about narrative medicine.
Yes.
And narratives, which again, OTs use kind of on the side. It's like, as you're treating people, you're just talking to them, but it's how do you get, can you use these narratives to get their stories that will really help you get more information on their, on where they would fall on the Burn scale, get more information on what needs to be focused in on, particularly in terms of resilience. I was thinking in terms of the moderate category, because I would hate for therapists to say, okay, this is moderate. All right, let me just tell the social worker to look at this, or let me just tell, this person to look at this. That's an OT job, right? So what's your thoughts on using narratives as part of treatment, especially after giving this, to try to how would you get the kids to, because these kids at this age, it's so damn challenging to begin with, but how would you get them to start telling their stories?
I think that's a great comment. Specifically speaks to me about the narrative medicine piece. I do have a small bit of a background with narrative medicine through actually my time in the master's program at Columbia, doing the Macy Scholar program, where I was first introduced to narrative medicine. And it's interesting you bring that up, because I think one way to improve the tool so that it could better help guide clinicians that wouldn't maybe otherwise be familiar with narrative medicine would, in that clinical implications chart, to expand on some more specific, maybe guiding questions, prompts, or steps they can take to help engage an adolescent more in that narrative to open up more questions. So I'm wondering, so that chart I'm referring to is the one that was in blue, that kind of gave some guidance on what you can do with the results after you scale it. And so I could expand on that guidance with some leading prompts, leading cues, and suggestions, especially for that moderate category. So it's not just overlooked and passed along to another discipline, but opened up more for us as OTs to question and gain more narrative.
Yeah, and that kind of, intersects with the resilience, with how do you use OT to foster resilience? You get the stories, and then you can use what's meaningful to them, to promote more participation. Can I ask another one, Dr. Graho?
Sure, yeah.
Okay. The other thing that I was really thinking about, and here I was kind of also putting my occupational justice hat on at the same time, were outcomes. And I think that we get stuck as OTs in terms of what kinds of goals and objectives we're supposed to achieve, and enable our clients to achieve when we're designing treatment. And clearly that's got to change. Our outcome measures too often are very limited to the site in which we're working, and it does not allow for participation. It does not allow to do the very things that your project has illuminated as critical. So, I'm wondering, what do we do? How do we change the outcomes that we focus in on? I'm not suggesting that we just throw away the goniometers, and those kinds of things, but how do we change what the goals really should be so that the paradigm shift that you're actually promoting, not just, specific to kids with burns, but for our profession, how do we change those outcomes? How do we incorporate, follow up and continue treatment? What do we do as professionals and as advocates so that our clients are not marginalized, if you will?
I have a few comments on that, but then also, is it okay to open it up to see if anyone else has some thoughts? Because I think this is a great question in general that from a lot of people here with different backgrounds and areas of practice might also be able to contribute. For me, I feel like we need to start thinking and revaluing the occupational profile part of our evaluations and part of our interactions with our clients. I think our therapeutic use of self, sometimes that along with the occupational profile and gathering those information, I think we do in a fast-paced setting try to gather what is the priority information we need in order to make the clinical decisions that follow, which makes sense. But I think also just being mindful of use of the occupational profile as a tool and use of our therapeutic self, that we do have these unique relationships with clients because we do ask them what's important to them and focus on that. I do think that's one way to start shifting in that direction as far as gaining more narrative and understanding more. How do we start to make that change?
I would love to hear other people as well.
Yeah, I would love to hear.
Back to Dr. Graho, or it's.
Sure. Can I ask my questions first, and then we'll open it up for conversation and feedback from the attendees. Thank you, Dr. Forecast. A great insight. And Amanda, congratulations. It's been truly such an honor and pleasure to have worked with you on this really exciting project. One big comment first is that I think one of the great things that you have in this work and in your practice model was really that fortifying of social participation from a functional cognition perspective. Just as a backstory for everyone, when Amanda's practice guideline was first sent to me as a draft, it was supposed to be a 20 to 25 page manuscript. It was a 45-page manuscript, really rich on the cognition pieces. She really tried to look at all of the essential literature to support the functional cognition piece of social participation. And of course, my first email to her was, we need to trim this drastically, which we did. And I think it was manifested by the feedback from the peer reviewers. It was accepted pending minor revisions on first round. And all of the feedback was that it was such a well-detailed, well-written, and a very useful practice guideline. And I think that alone, this manuscript, this publication alone will be such a great contribution to the field of functional cognition and looking outside of what we typically address for patients with burn injuries. My primary comment is I want to sort of relate this to one of the comments by Dr. Falk-Kessler, and primarily on the need to build capacity and translate knowledge so we expand the scope of practice for this population. I think that was very apparent in the feedback of your content experts on some of the 12 items that were deemed not very essential in your tool. So remember, it was a 30-item questionnaire, and there were 12 items deemed non-essential. A big chunk of them, I believe, correct me if I'm wrong, were from the social supports domain. I think from the OTs who reviewed this, they all advocated these were essential, but for some of the PTs, the doctors, the non-OTs who were content experts, but are experts in burn injuries, were the ones who questioned the need to assess the social supports of adolescents with burn injuries. So comment a little bit on the reasoning they provided on why these were not essential. And again, comment as well on the need for us to really advocate for knowledge translation that, you know, particularly from an interdisciplinary perspective, we need to move outside of the medical model of addressing many populations, but particularly for you, for adolescents with burn injuries.
Sure, that's a great comment. So you are correct. There were, just as a reminder, there were multiple disciplines that reviewed the content to say if it was essential or not to the tool. And we were trying to condense the tool so that it could fit that screening, more of a screening tool, and it could fit something that was very quick and easy for an adolescent to complete. So with the social supports domain, looking at what supports someone may have in place as far as their own caregivers. So within the unit that they're living, within the outside of the home, where they're out at school or in the community. So that aspect, a lot of the questions were just kind of rated as redundant by some of the other disciplines, that they just didn't feel that they were, I got a lot of more, it's useful, but not essential. And so I think that part of the advocacy for explaining why it is essential, I mean, there's research out there across the board in all of mental health practice that social supports and social participation is critical for somebody's mental health and well-being. And that's in general. And you can find a lot of research that supports that concept. It's not a new development. And so I think part of our role is just being able to advocate and maybe link some of that more general literature to just bringing it to the forefront that that this is something that is important, and that there's plenty of research out there. I think it's just bringing it to light, honestly, bringing it to conscious awareness that this is relevant to this population. And I think that is a good starting point as far as trying to help understand that it's not just the healing process that's impacting the adolescents. It's also looking at what supports they have in place, because when you are supported by others, then you have someone you can disclose things to. You have someone that you can at least just feel like you can be yourself and not hide. And I think that that's one aspect that helps maintain a balance of, we're talking about trying to avoid things like anxiety and depression in the long run. And so again, isolation is known to facilitate some of those things.
Mhm.
So back to the original comment, I think that just being able to advocate, especially in this particular scenario, in a burn clinic setting where we are looking at, the medical things that we need to look at and address, of course, but then making sure that when we have the opportunity, that we make a conscious effort to ask these questions and to educate team members why we're asking these questions, so that it starts to become more of the norm, that it's something that is just integrated into practice.
I have another question, but in the essence of time, I want to start addressing some of the questions from the audience in the chat. I want to thematize two great questions, one from Dr. Kat O'Neill and another one from Dr. Gillen. Do you see the SPI burn being used or sort of generalized to other populations who might also have other body image issues or other challenges such as amputations, other differences such as stuttering, atypical gait, facial deformity, etc.? I mean, because the title itself is very, very specific to adolescents with burn injuries, but can you comment on that?
Yeah, that's a great question. So I made a very intentional move to name the SPI burn, the SPI burn. We wanted the word burn in it. We wanted that to be loud and clear. And that really came from the scoping review, where it was found that there's so many tools that are used. There was 156 tools that were found in general used by interdisciplinary team members, so not just OTs. This was psychology, social work, physicians, nursing. It was all across the board. And most of the tools that were being used were tools that are used in general or designed for other things. So I wanted to make a conscious attempt at labeling something a tool for burn injury specific for this population, with that goal of just having something that was more direct to this population, to make sure we're capturing the things that may not be adequately captured by other tools that are for more general populations.
Mm-hmm.
So while I do think that it's possible to maybe generalize to certain other populations because of the wording and terminology is more on scars. In a lot of the questions, it says because of my burn injury or because of my scars. It may not be applicable to other populations unless there was something maybe with a surgical, some type of surgical change that caused a scarring or type of physical change. But otherwise, it's very specific to burn injury, but with that intentional effort to do so.
I want to paraphrase a question from Dr. Sarafian. The SPI burn measures a lot of social participation, particularly from an in-person perspective, getting dressed. When we brainstorm about this, making sure that, your burn injuries or scars might not be as visible, or being self-conscious when your burn injuries are easily seen by others in a social situation. But could you address whether the tool might sensitively capture other forms of social participation, particularly in the COVID area where everything's happening on Zoom? You have a 2x2 frame on Zoom where you only see part of your body. Also the use of other social media platforms where you're able to socially connect with each other, but having a control of your narrative or what pictures you post in, etc. Do you think those kinds of social participation will be captured by the tool?
That's a great question. And a lot of the question design occurred prior to COVID, and a lot of this coming to light. What I do think the tool does a nice job doing is the questions are more general and chunked together, such that the way that they're presented, because they're presented in a way where the adolescent is reporting, I feel like the appearance of my burn has changed how I get dressed in the morning, or change the clothing that I pick out, or I would be choosing different clothes if I didn't have this burn injury. So the way that they're phrased, because it's more interpersonal, the way that they're phrased, I do feel like it could capture aspects of that, but I think it's a great question. Looking at Zoom, I'm not. I would have to relook at that, to be honest, and see if there is room for revision or addition, even because the tool has 18 items right now. So for me, there is addition for 2 more items that make it a solid 20 questions. And I think that's a really great comment.
Yeah. One more question, because we're we're actually out of time. It's a great question from Dr. Hamed.
Yes, thank you.
And remember, and several of our OTD students are here. My phrase in life in the OTD program is slice your pie small. But when we designed the SPI Burn, we initially designed it as a descriptive tool. The purpose is to create an index, sort of like a social participation profile. And until we've done rash analysis, Amanda, it's hard for us to determine whether it's sensitive enough to capture the evaluative pre-test, post-test nature of it. And that is actually Dr. Hamed's question, is that do you plan, or do you foresee the tool as being an evaluative tool that can be used as an outcome measure, pre-test, post-test, to determine whether a particular social participation or mental health or a resilience intervention was able to increase or enhance their social participation after a certain period or dosage of intervention?
That's a great question. I think, as Dr. Rajo, just to reiterate what you said, the first step is to go through the construct validity testing. And granted that rash analysis goes well and the questions do in fact measure that construct, I do think with design of the practice model or the guideline for practice that I created, I do think that I envisioned it as a pre and post test, such that the elements that it's looking at are aligned with the elements that the practice model are also targeting. And it's also aligned with the gaps that were identified in the scoping review. So it was strategically designed to align with those 3 pieces, to hopefully in the future be able to use it as a form of a pre-test, post-test measure.
Excellent. I'm going to wrap it up because we're out of time, but lots of great feedback and comments on the chat, Amanda. But before I officially wrap it up, I just want to show this. Congratulations. Excellent work on presenting your capstone. And we can now unofficially address you as Dr. Amanda Lange. Thank you for all this excellent, great work that you've done. And again, there's a lot of comments on the chat congratulating you. But once again, congratulations on this work. You will receive the summarizing comments from me and Dr. Falk-Kessler shortly after this call. For all of you who joined, I see a lot of our OTD students, a lot of our faculty here with us this morning. Thank you for joining us. I'm going to stay on the call for another 20 to 30 minutes just for people who want to stay and congratulate Amanda and celebrate with us this morning. But I know several of you just carved out an hour of your clinic work and other responsibilities to join us this morning. But thank you for joining us. We are expecting about 4 OTD candidates presenting their capstone sometime late spring or in the summer. So hopefully I'll see many of you again and join us during those presentations. But once again, congratulations, Dr. Amanda Lange. And for all of you who need to go, thank you for joining us this morning.
Thank you.
Again, I'm going to stay for a few more minutes to congratulate Amanda. You can all put on your cameras now. You can unmute yourselves if you want to, and wish congratulations to Amanda.
Oh my goodness. Thank you all so much for being here.
Well done. Well done. Amanda, it's so nice to see where this project came from, and I'm so glad I was able to share, and see where you came, not only as a beginning entry, and Jason says congratulations too, but I'm glad that we were able to share this journey together. So congratulations, very well deserved.
Likewise.
Thank you for joining us, Phyllis.
Jason, you were little when I first met you.
He's not so little anymore.
Anymore.
Congratulations, Amanda.
Congratulations.
Work. Wonderful work. I'm so very proud of you. Look at this. It's an amazing, amazing project, and
Thank you.
very, very well deserved doctorate and process. I can't wait to see where it's going next. So keep in touch. I have to go, but I'm really, really proud, and congratulations.
Thank
Take
you
care.
so much.
Congratulations, Amanda. We're so proud of you.
Thank you, guys.
Oh, so your puppies, congratulations.
Yay, yay, yay.
And I'm so glad that I had the opportunity to be your reader, because as I said, I learned so much. I just thought it was wonderful. I loved it.
Thank you. And I know you
Thank you.
have so much work on these things as well. And so I thought it was just a nice, that there could be a lot of great feedback. Oh.
We also try to always just get Dr. Kessler out of retirement and do some work for us in the doctoral program. So thank you, Janet, for carving out time for us.
Yes.
I feel like I'm not retired anymore.
And you have nieces and nephews congratulating you.
You can unmute, Tara. Yeah.
Hi.
Hi.
We are so proud of you. Job well done.
Thank you so much.
About the parents. Parents, say something.
Yeah. Unmute yourselves.
Unmute.
Just come over
Unmute,
here.
Michael.
Oh.
Or you can join Amanda there on the other side.
Oh my God.
We were on mute. We didn't know.
I thought you were in her house, not his house.
Thank you.
Yay. Long journey, niece, long journey.
It's been a great one.
Very cool.
Hi, Bernheimers.
We got Nick down there.
Is Nick, say something.
Nick?
Ah,
He's sleeping.
He's on mute.
No, it's her.
probably.
Yeah,
All right, next
Thank you all
chapter,
so
man.
much for being here.
so exciting.
And Amanda, once the recording uploads, the text of all of the messages get stored as well. So if you were not
Okay,
able to see all of them, I can
That's
send
great. That's what I was trying to read through. So that,
congratulations from people. Nick just posted a message.
He did.
He might be camera shy. He just said congrats.
okay,
Nick,
there we go. Thank you, Nick.
Is Nick your brother?
That's my twin
I'm-
brother,
oh,
yes.
oh, no, I'm not. My twin brother, yes.
Oh, all of the nieces.
We saw you, Lisa.
and-
Amanda, Catherine, and Kevin, congratulations.
Thank you.
You're welcome.
I was looking to see where that was coming from. Now I found you. That was Catherine.
Oh.
Catherine is in California right now. It's
Oh, wow.
early.
It's early, yeah.
That is-
Yeah,
You-
something like
You're going to work soon.
Yes, hence why the camera's not on. I'm getting ready.
that. Okay.
So cool. Very cool. Hi, Bernheimers. Hi, Lori. Hi, Zach. Everybody.
You can mute yourselves if you want.
Hi,
Hey,
Gail. Yeah, well, there you are.
This is so cool.
So congratulations,
There
everyone.
was a lot of different states here.
Dr. Lange, I have to get used to that. Oh, no. Wow, really
I
great.
bet you I'm in the warmest state though.
You are.
You are.
Yep, Florida. So, well, I have to go to work also right now. So congratulations.
Thank
Well
you.
done. Long journey. New chapter for you, Amanda. New chapter.
Mhm.
All right. There's a lot of people that are going to need you out there. Bye, everybody.
Bye, Gail.
I thank you for
Bye-bye.
Bye.
joining us. Any other messages before we end the Zoom call? I'm sure there will be a continuing external Zoom call or FaceTime call afterwards. Any other messages for Amanda? I actually want to see your brother. Your brother's just quiet over there lurking. Is he also in Ohio?
No, he's in Vegas.
Oh, in Vegas. It's also 7 o'clock, probably still in bed perhaps.
Why doesn't he come? Yeah, he's probably in bed. He's probably in bed.
Oh, yeah, exactly. Well, thank you all for joining us. Thank you, family. Thank you, Mike. Thank you, the Bernheimers and everyone who joined us today. Amanda, I'm so, so proud of you. Almost done, just finalizing touches. I'm sure the comments, I'm sure the comments will be very minor. And then the manuscript is, of course, now on your own pace. But hopefully we're gonna get that done soon. It's nice to have a second publication out. And this will easily be accepted in OT and mental health. But I'm truly, truly proud of you. We don't know yet what the spring will look like in terms of a formal graduation ceremony. But even if we don't have an in-person ceremony, we will definitely have a virtual, more formal, official virtual hooding process for all of you. Because like I said, there'll be 4 other people defending their capstones later on, plus Josh, who we also have not formally celebrated on a graduation. So there'll be technically 6 of you. But like I said, your degree will be formally conferred in February. You can start using the doctor and the OTD title today in your email, in your signature, get a new business card, all of those exciting things once you earn your doctorate. But I am so incredibly proud of you. Such a remarkable, intense, hard worker. And it's been such a pleasure mentoring and working with you on this project. So, as I've told any other OTD student, our partnership doesn't end after graduation. I'm sure we will continue working on this project. We can write more papers together, but the luxury of that is now it's on your own time and when you're ready. But again, congratulations. Incredibly, incredibly proud of you.
Thank you so much for everything.
Absolutely. And hopefully we'll celebrate in person sometime. There's no more Cougans.
I know.
Their Cougans has closed, but hopefully.
That's the little bar he's talking about up by the medical center, the little Irish place.
Yeah, but hopefully we'll be able to celebrate in person. I'm actually gonna head out soon to get my second COVID vaccine trial. I'm in a trial.
Oh.
Getting my second shot in about half an hour. So, but again, congratulations. Thank you everyone for all of your support and hard work as well. Incredibly proud of you, and we will be in touch, okay?
Yes, Nikki.
Thank you. Celebrate.
Congratulations.
Bye, guys.
Everyone. Take care.